welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
And we're going to look at the article, The Effect of Intravenous Push and Piggyback Administration of Ceftriaxone on Mortality and Sepsis. Ultimately, this article attempts to answer the clinical question if the administration method of intravenous antibiotics has an effect on the mortality rate in sepsis. So our objective today is to determine the difference in 28-day mortality between intravenous push and intravenous piggyback. So some abbreviations that are going to be used today include IVP for intravenous push, IV piggyback for intravenous piggyback, as well as some other commonly used ones, and then finally SOFA being the sequential organ failure assessment. So when thinking about the logistics regarding IV push versus IV piggyback ceftriaxone, there are a couple things to keep in mind. So IV push is recommended to go over 3 to 5 minutes, but as we know in practice, sometimes nurses push it faster than this. Whereas an IV piggyback administration is recommended to go over 30 minutes. IV push, additional equipment required. It will just be, they can either come in pre-mixed vials or some type of nurse admixture. Whereas an IV piggyback, it'll either be pre-mixed bags or there's sometimes a compounding requirement. So IV push has minimal additional equipment required. So everything that, is typically stocked in emergency departments. So things like flushes, needles, syringes, and things like that. Whereas an IV piggyback typically requires some sort of drug delivery pump recommended, sometimes in the nick of time. Sometimes an IV piggyback is hung against gravity, but it's recommended to be hung with a drug delivery pump. So some common IV push beta-lactams include ampicillin, cefazolin, cefotaxime, ceftriaxone, ceftazidime, cefotetan, as well as meropenem. So the Surviving Sepsis campaign does put an emphasis on time to antimicrobials and provides a recommendation that administration time of antimicrobials should be less than 1 hour in patients where sepsis is considered definite or probable. And the guidelines also recommend that in situations where sepsis is possible, antimicrobials should be administered within 3 hours. Each hour delay in administration of antibiotics is associated with an increase of in-hospital mortality in septic shock patients. In patients without shock, the time to antimicrobials have been shown to have less of an effect on mortality. So now we'll look at some of the previous studies surrounding IV push versus IV piggyback antibiotic administration. So the first study did compare IV push to IV piggyback beta-lactams and found that IV push beta-lactams did have a higher incidence of adverse reactions. The most common adverse reactions were shortness of breath. There was even infusion-related reactions as well. The second study compared the time from sepsis diagnosis to antibiotic administration for the IV push group and had about a 30-minute time reduction compared to the IV piggyback group. And then the final study, we're all, I'm sure, familiar with, is a study that was published by Kumar. It was a multi-center retrospective review trial. So looked at the survival to hospital discharge and looked at the intervention that basically looked at antibiotics that were administered after a patient had sepsis-induced hypotension. Ultimately found that each hour delay in initiation of antibiotics resulted with a 7.6 increase in mortality rate. So now digging into the study. So this was a single center retrospective analysis that was done between March of 2010 and February of 2019. Patients were divided into two groups, the first group being an IV push group, where the IV push was administered over 2 to 5 minutes, and the second group being the IV piggyback group, where IV piggyback was administered over 30 minutes. And the remainder of the sepsis care was based on the Survival of Sepsis campaign guidelines and ultimately up to provider discretion. So when looking at inclusion and exclusion criteria, the patients had to meet the septic and or septic shock criteria. The unique thing, so because this trial was from 2010 to 2019, the definition of septic and septic shock changed in March of 2016. So here you can see the initial definition was based on the Second International Sepsis Definition Consensus. And then from March 2016 to 2019, it's based on, Sepsis 3. So Sepsis is defined as a SOFA score greater than or equal to 2, and then septic shock is defined as persistent hypotension that required vasopressor medications to maintain a MAP greater than or equal to 65 despite fluid resuscitation. Some other inclusion criteria that patients had to be initially treated with ceftriaxone, and then as well as receive a negative allergic skin test. And I did put an asterisk by this because while this was not listed in the inclusion criteria, if patients had a positive allergic skin test, they were not administered ceftriaxone. Other exclusion criteria: known pregnancy diagnosis, any patients that refuse life-sustaining treatment, patients with missing data, or transfer from an outside facility. We'll get to it, but the transfer was actually a pretty high number of patients, and because the site for this study, a very large tertiary care center that did receive a lot of transfers from smaller hospitals. So when looking at the primary outcome, ultimately the primary outcome was the 28 mortality rate after admission to the emergency department. Some secondary outcomes were ED arrival to antibiotic administration time, to determine if antibiotics were administered within 1 to 3 hours of presentation, the administration of appropriate antibiotics, and the study did define appropriate antibiotics, so it was kind of a two-step thing. So step one, it was considered appropriate if the bacteria that was cultured was susceptible to ceftriaxone, and then if there was no bacteria identified in cultures, it was considered appropriate if the Stanford guidelines did recommend ceftriaxone for the indication of the sepsis. Other secondary outcomes included the presence of septic shock, as well as the rate of hospitalization in an intensive care unit. And then for safety outcomes, they looked at the rate of adverse reactions. I do want to note that this study really defined their adverse reactions as what we would commonly refer to as allergic reactions, and really didn't report some of our GI side effects and stuff like that might be reported with other studies. So statistical analysis, so continuous variables were tested using the student's t-test or the Wilcox-Rank sum. Categorical variables were testing either using the chi-squared test or the Fisher's exact test. Survival curves were plotted using the Kaplan-Meier method, and a multivariable Cox proportional hazard regression analysis was used to determine the relationship between administration method and 28-day mortality. So almost 4,100 patients did meet exclusion criteria, but only 939 patients were actually enrolled in this study. So that's why there was, like we said, there was a very prolonged enrollment time, especially with the volume of this hospital. So the most common causes for exclusion were patients who were transferred from another hospital, if ceftriaxone was not used, and if patients were refusing aggressive management. And then of the enrolled patients, almost 300 were in the IV push group, and 640 were in the IV piggyback group. And one thing that's interesting about this is that it was not stratified. So even though that it looks like it's about a 2-to-1 ratio, this was not done at all by the investigators, but this is actually based on how the hospital practices. So generally speaking, baseline characteristics between each group was not statistically significant for a difference, but we did have some notable differences. This would be our baseline SOFA scores, initial lactate, systolic blood pressure, and heart rate, all favoring the IV piggyback group. As you can see, the initial SOFA score was 1 point lower in the IV piggyback group, the initial lactate was lower, initial systolic blood pressure, and then initial heart rate were also lower in the IV piggyback group. So this is probably ultimately driven by the SOFA score. So as you can see, the components of the SOFA score include things like platelet bilirubin, mean arterial pressure, Glasgow coma scale, renal function, and stuff like that. When looking at between our blood, urine, respiratory, and body fluid cultures, microorganisms were identified in almost 60% of patients. So the most common organism that was identified was E. coli, that was found in almost 30% of all patients, and then this followed by Klebsiella, which was identified in almost 15% of patients. And the Streptococcus did make up about 10%, and Staph aureus about 6.4%. One thing to note is that the study did not have any results on susceptibilities or rates of resistance or anything like that. So it's definitely a limitation. So when looking at the primary outcome, the mortality rate was about 12% overall. You can see the IV push group had a mortality rate of 12.7%. IV piggyback group had a mortality rate of 12%. So this result was not statistically significant, as you can see by a p-value of 0.851. This also is not a clinically significant reduction in mortality rate. So some of our secondary outcomes, so looking at median administration time, of course, this is statistically significant difference. As you can see, there was about a 26-minute difference between the two groups. The rate of adverse reaction, there was only one noted adverse reaction in the IV push group, and there was no noted adverse reactions in the IV piggyback group. Appropriate antibiotics, this was not statistically significant. It could be about 5% difference between the two groups. Septic shock, there was no difference there, with only a 3% difference in groups between septic shock. And then ultimately, it was identical ICU admission, with both groups having an ICU admission of about 29%. So now when we're looking at the Cox proportional hazard regression analysis, comparing sepsis or septic shock, there's a couple things listed here that really have an effect on mortality. So these things like initial SOFA score, infection sites, intra-abdominal sites, so things like that do have an effect on the Cox proportional hazard regression analysis. But then ultimately, it's not what is not significant is the difference between IV push versus IV piggyback. And then when looking at the Cox proportional regression analysis, so we're looking at septic shock specifically, whereas the other one looked at septic or septic shock patients, you can see it's the same thing. Certain things do lead towards less of a hazard ratio. So this would be like urinary tract infections, intra-abdominal stores, stuff like that. As you can see, there was no difference between our IV push and our IV piggyback group and the Cox regressional analysis when looked specifically at the septic shock patients. So even though, that to say, overall, what I wanted to kind of pull from these two Cox proportional regression analysis is that there's no difference between the IV push and IV piggyback group in mortality in sepsis or septic shock. So this does bring us to the discussion. I think there's definitely a lot of things that we can talk about here. So the authors concluded that despite the faster time to administration, overall there was no difference in 28-day mortality. They also noted that there was no adverse effect difference between the group. We'll get to later, but that's definitely a limitation, though, of the adverse effects that they looked at. Some other limitations that the authors did note is that this was a single-center retrospective study, and that a majority of patients did receive other antibiotics along with ceftriaxone. It would be hard to specifically say that not only ceftriaxone made a difference in the mortality rate, but that the difference of administration in ceftriaxone made a difference in mortality rate when patients were receiving such other forms of therapy. And then this was a limitation, and the authors also did not report what other antibiotics were used. So some critiques that I have about the methods. So there was no power analysis performed to determine enrollment numbers. And like I talked about, right, so it was almost a 9-year enrollment, and this was, a very large hospital, and it took them that long just to enroll about 900 patients. So I definitely think that that's, something to keep in mind. And then like I talked about earlier, so enrollment based on route was not stratified. Ideally, we would like to see this being a 1-to-1 instead of how it kind of played out to a 2-to-1. And then all patients did receive an allergy test prior to receiving ceftriaxone, which is really why their adverse event rate was so low, not only because they didn't report some of the common adverse effects, GI side effects and stuff like that, but what they identified as adverse effects or report as adverse effects were things that we commonly think about as an allergic reaction. And if you do an allergic skin test before receiving ceftriaxone, then you will have less rate of adverse reactions. And really, that's really just not feasible in practice, right? So in a disease state like sepsis or septic shock, where time to antibiotics really does have an effect on outcomes, really just not appropriate to get an allergic skin test on patients before we give antibiotics. Another thing to keep in mind is that the minimum age was 73 years old. This is a very old patient population. There was one participant that was under the age of 65, but other than that, everyone else was over the age of 65. The median age is 73, which is actually surprising with the older age, and we'll get to it, is that the mortality rates were pretty low compared to some of our other studies. And there was a statistical significant difference between baseline SOFA scores. Having that difference could indicate that our IV push group actually maybe had slightly worse sepsis. And then, like we talked about, so other aspects of sepsis management were not reported. Things like vasopressor requirements, things like the amount of fluid that was administered, anything like that really wasn't reported, which, as we know, are main drivers that affect the outcomes in septic patients. If they could have illustrated that, the difference between the two groups was nearly identical with other aspects of sepsis management, I think we could pull more from this study. But when we really don't know how these patients were treated outside of their ceftriaxone route, it's hard to say that this has any impact on mortality or anything like that. And then looking at the primary outcome, so there was, like we said, so there's no difference in 28-day mortality in the groups, and there was a 12.7 in IV push and 12% IV piggyback. And overall, that's a pretty low 30-day sepsis mortality compared to previous trials and literature. So SOAP2 quoted mortality rates around 50%, and SOAP2 also only had a median SOFA score of 9 compared to the study that had a median SOFA score of 7. So once again, a slightly, you could say, sicker patient population that we see in a landmark trial, SOAP2. So that's just some things to keep in mind. Maybe these patients, aren't as acute as maybe populations that we see today. Looking at some secondary outcomes, so the median time from ED arrival to initiation of antibiotics was 176 minutes, which is crazy to think that this was almost 3 hours that it took to receive antibiotics in a patient that presented with septic or septic shock, when, as we know, guidelines recommend, within 1 hour if sepsis is probable or shock is present, and then within 3 hours if sepsis is considered possible. And I think that a big thing why their delayed time to initiation of antibiotics was so long is because they were doing the skin testing on their patients as well. And then, like I talked about, right, with this allergy pre-screening, there was only one adverse event that was reported due to allergy pre-screening. So ultimately, what is the conclusion that we can get out of this study? So I kind of split into two things. So I'm thinking about what impact does this have on clinical practice, right? So there's kind of two trains of thoughts, right? So you could say with no difference in mortality, IV piggyback will limit the amount of nursing time that's required, right? So if nurses do the IV push the appropriate way, they'll have to be at bedside, pushing an antibiotic for 3 to 5 minutes. Whereas theoretically, if the supplies is available, IV piggyback, by the time the nurse spikes the bag, hangs it, and, programs the pump, the nurse could walk away at that point, and wouldn't have to stay with the patient. But then some also things to keep in mind is that IV push does not require any additional equipment. And in RED, there's definitely a shortage of pumps, right? Especially if there's a lot of acute patients that are requiring multiple pumps. It could be that, we have to move pumps around from room to room and stuff like that. I'm sure, isn't just at our institution, but a lot of EDs, especially now, post-COVID, with how crowded EDs are. Also, IV push can be administered in triage. So at our facility, we do not have medication pumps in triage, because theoretically patients should not be in triage long enough to receive an antibiotic, piggyback. But an IV push, if IV access is established, theoretically this IV push can be administered in triage because it shouldn't take longer than 5 minutes. So looking at future considerations, I think that, a multi-center study in patients with higher SOPA scores really could maybe help capture patient population better. I think that really with these lower SOPA scores, which then in turn went to lower mortality scores than we typically see in our sepsis patients, it's really hard to kind of extrapolate this study into current practice. And I would think that also comparing IV push to intramuscular ceftriaxone would be something good to look at. I think that if intramuscular ceftriaxone, theoretically, IV access, it could be administered within, a minute of the patient firing for sepsis. As long as the supplies are at hand, you don't have to get IV access, anything like that. Could potentially, I think, be interesting to see if that has an impact on practice. So I think ultimately, I don't think an institution should swing one way or the other. I think there's definitely pros and cons to both. And I think ultimately it should just depend on nursing staff and kind of how the flow of your institution runs, or if IV piggyback should be continued, or if maybe this trend to IV push should be continued. So I would ultimately like to thank my mentor on this, Dr. Lisa Hayes. Thank you for all the help on this and really helping guide me through this. Thank you.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.